Hello and welcome to the latest ECIST podcast. My name's Giles Adams. I'm an improvement manager and I work with the ECIST team. And I'm delighted today to be joined by Lesley, and we're going to discuss delegation of insulin administration. So Lesley, would you like to introduce yourself?
Thanks, Giles. So my name's Lesley Mills, and in my substantive role, I'm a consultant nurse in diabetes up in the northwest of England. However, I'm on secondment to the national team at NHS England, and I'm a community nurse fellow in the nursing directorate, and I'm being hosted by the North Eastern Yorkshire region.
Wonderful. Thank you, Lesley. So let's start. So could you describe the delegation of insulin administration framework for us?
Yeah, so this was established a couple of years ago when the national team, led by Sam Sherrington, put together a group of individuals, clinicians, stakeholders, because they identified the fact that it's challenging times for community nursing teams, and we needed to look at how we can release the workforce pressures and give them greater flexibility. So this framework is to equip those non-registered staff, those healthcare support workers, with the right skills and the competencies and confidence, which then can help reduce those unnecessary delays in delivering insulin in the community.
Okay, so I'm starting to think there's a lot of benefits here, and I guess the most important benefit that we're looking at is the benefit to the patient, who can have their insulin regulated in a slightly different way. So would you like to talk a little bit about that? And I think you might have a patient story for us to bring that to life.
Yeah, so the programme itself is underpinned by 6 simple principles governing the delegation of this task from registered nurses to healthcare support workers. And they've been informed by the CQC, NHS resolution, the RCN guidance, etc. And those 6 are safety. So the delegation will only happen if it's safe and an organisational risk has been assessed. That it's of patient or personal individual benefit. So the goal of all those changes to the way of working is to continue to improve that quality of care and support for those individuals. That we have support, that there's support for staff across health and social care as well. And that's that all these changes need to empower those staff across the sectors and respond to those staff concerns. That it's voluntary and discretionary. So that delegation of tasks at a system, organisational or even individual nurse level will remain voluntary and is subject to the discretion of that registered nurse. So I'm a registered nurse and it's at my discretion whether I delegate that role to that healthcare support worker for that procedure to carry out. And it's in to make sure that the recipient of care is happy about this, that their wishes and also my ability, the registered nurse's ability to judge the judgment of the ability of the healthcare support worker to do that new role. And then obviously I mentioned the support of the regulators. So these have all been agreed, with the relevant quality and governance and performance regulators, as I mentioned previously. And then the most crucial bit in all of this and is about that training and support, that's in place for all levels. So that registered nurse needs to be able to be confident and competent in what the ask is, and that we've got enough materials and advice to support that, and that the training and support for that healthcare support work is in place. And if I give you an example, community nurses all over the country will have many patients and people that they care for, like the one I'm going to talk about. But Iris is a 92-year-old lady who has had type 2 diabetes for many years and lived at home independently with her husband until 3 years ago when she had a stroke. And after that, because of her dexterity, she wasn't able to give her insulin herself. So her husband took on that as a carer and gave her insulin the same time in the morning, the same time in the evening. She could have her breakfast and her evening meal as she would normally do. And then her husband suddenly died, and Iris was left on her own. She had full capacity in regard to living at home, but the district nurses needed to take over that role of administering her insulin. And in the early days, because the district nursing team couldn't guarantee what time they would arrive, as many teams have hundreds, if not thousands, of injections to do daily. It could be 8 o'clock one morning, it could be 11 o'clock one morning. So Iris was waiting for her breakfast until she'd had that insulin, and the same with the evening meal. And in those first several months, Iris had several admissions to hospital with hypos. Her mental health deteriorated, her weight reduced because she wasn't able to eat at the time when she was used to. So a package of care was put in for her, got her back on track, but the district nursing team decided to delegate that administration of insulin to the healthcare support workers, and 4 healthcare support workers took on her case. And between them, they built up the continuity of care. They were able to give Iris that insulin in the most timely manner. Iris built up the trust and understand and that confidence from them as well. And they would very quickly be able to see if Iris was deteriorating or any care needed to be accelerated up to the registered nurse. And in the last 18 months, Iris has not had one hospital admission or A&E attendance, which is wonderful. Those healthcare support workers are very proud of what they've achieved. It's given them the confidence, to carry on with the role, but it's also demonstrated to their colleagues as well what they're doing. And so then that encourages more to take on that new and extended role. So if we can do that with Iris, then we can do that with a lot more.
And what a wonderful story that is, Lesley. And Iris was at a really vulnerable point in her life when she sadly lost her husband, and what she needed, yes, she had the care and dedication from the district nursing team, but as you said, demands on their time are vast. So to get that consistency and that trust back was so important. And as we know, every hospital admission carries a degree of risk, and risk that maybe you don't get back to your home, and the risk of becoming deconditioned. So it's so important that we can keep people like Iris away from hospital and healthy and safe in their home. Wonderful story.
And I think something to add on that, Giles, is the fact that it actually released that qualified nurse, that registered nurse, to look at that flexibility, I suppose, and response to team working. So then they were released to do perhaps more complex reviews in a much more timely manner, which meant that they then felt happier in their work as well. So from a staff retention point of view, from a caseload, safer staffing, hospital avoidance, again, for another group of individuals, it impacted on those as well. So it really is a benefit to all of those who we're talking about.
It seems like the benefits are in every direction for this. And I think you might have some statistics for us on how much time that this has potentially freed up for some of the nursing teams in certain areas, because I think our listeners will be quite shocked at quite how vast that is.
Absolutely. So a really good example is Sheffield. In Sheffield, one of the community nursing teams who rolled out this delegation of insulin framework to those that were going into individuals' own homes. So they administer 454 injections a day, okay? And they decided to take on adopt this framework, and they delegated only 23% of those to healthcare support workers. So that was 104 injections a day that healthcare support workers were going out. That saved them nearly £69,000 a year. okay, which they have put back into the workforce and developed and been able to appoint more staff. Sussex is another great example where they have demonstrated that the rollout in care homes, and this was where it released capacity of the district nursing team. It improved that quality of care to the residents in care homes, and it reduced that unnecessary delay in delivering the insulin for people living with diabetes. So improved that whole cross-sector working, and obviously that resilience of the shared community workforce. That resulted in their pilot of 5,425 hours a year in the district nursing team, which was a cost saving of round about £76,000, but that was just in the pilot. Since then, they've gone on to do even more. So it's phenomenal, the amount of hours saved. So even from an economic value, it's that, but from a workforce, from that cross-sector working, from that patient individual satisfaction, from the staff satisfaction, and that hospital avoidance, that A&E attendance, all of those, to me, and I'm sure to those who are already doing this, it's just a quality improvement.
It absolutely is, and you've told me those figures before, and I nearly fell off my chair. It's astounding, and those figures relate to people like Iris, who are able to stay at home where they want to be, where they're safest, where they thrive. The healthcare assistants who are able to extend their skills and potentially look for maybe new careers into nursing because they're inspired by doing more skills, and the nursing teams that are freed up to help more people with maybe more complex needs. It's just incredible, and I imagine, as you said, financially, commissioners should be looking at this and saying, wow, we need to be doing this. So if another area wanted to do this, what would they do? How would they go about it?
So there's the whole framework, the competencies, the checklist, the actual e-learning, webinars, everything is being housed on the Diabetes UK website. And we'll share the link, and it's my QR code behind me. For those providers that perhaps need to be linked in with another team or organisation, then I'm part of my fellow role. I can do that. I can talk to an organisation, or one of the other fellows can support sharing of information, or we can actually, sit down and see what needs are for that organisation or that system, and we can support, because we're really keen, and the national team are very keen to get this rolled out across the whole of England. So anything we can do to provide support and guidance around that, then we can do that.
So that's fantastic. So no one has to go out and reinvent the wheel. All the resources are there, all the training is there, all the support, all the peer support, which is so important to be able to link in with people that have done it and will know some of the pitfalls and the areas that, to focus on. And ultimately, there doesn't seem to be a negative side to this. It's just such a fantastic initiative. And Lesley, you've talked us through it with such passion. It's clearly something that you are passionate about. We will share all of the links. We will make sure people can access them, and you've put your QR code there, which is genius, so they can link straight into the Diabetes UK website. So that's great. Is there any final thing you'd like to say before we sign off?
Yeah, if people listen and watch this podcast and then want to start a discussion, we're going to put a discussion board up on our community nursing platform on the Futures. And so then we can answer quick questions if need be, or put people in touch with whoever.
Brilliant. Thank you. And we'll put all the links at the end of the video. And if anyone wants to get hold of us, get hold of yourself, get hold of me, or get hold of the ECIST team, whoever you need to get hold of to link in with the right people, we'll make that happen. And let's create more people like Iris who can continue living safely at home, fulfilled lives.
Excellent. Thank you.
Thank you, Lesley. Thank you for your time today. It's been a pleasure.